5, 4, 3,
2,
1.
And we are live. Is that correct, Ben? We are live. Good morning, everybody. My name is Jens Chapman. We have a big echo here. Today is August 7th, 2024. It's the beginning of the new academic year. Again, my name is Jens Chapman. I'm speaking to you from the beautiful Seattle Science Foundation facilities. And we have a very cool speaker today, Dr. Stephen Lockey. He's the official NAS traveling fellow, and he's attending at the University of Virginia. And we were very privileged to be able to host him here, together with noteworthy other places such as the Hospital for Special Surgery and the Rothman Institute. And during his time here, Dr. Stephen Lockey gave a lecture on bone healing, and especially as our young trainees get used to hearing a lot of industry presentations on bone healing, we thought that getting into the foundations of bone healing, which is so much at the kind of cause for concern and focus of many of our reconstructive surgeries, also implant-based surgeries, I thought this would be a great occasion to redo this talk. STED Talks, Spine Technology Education D is discussion, discovery, discourse, debate. This D will be heavily at stake as we're looking at our customary first cases, and we have a very cool crop of 4 new fellows there. One of our old fellows may call in. We have some technical difficulties with him in the state of Illinois, but we'll start with Dr. Mark Kramer from the University of Wisconsin, a neurosurgical colleague, and he has a noteworthy case. Dr. Lockey, are you live? Can we have audio from you?
I'm here. Thanks so much, Dr. Chapman. And may I say thank you for using the picture of me 7 years ago before 3 kids. I appreciate the youthful look there. That's kind of you.
So it's great to hear your voice. Thank you for taking the time to do this. Dr. Kramer's going to come up. He's going to show a case that has not yet been resolved, but that you can help us with in terms of what to do, but also analyzing what went wrong. So.
All right, it's great. So my name is Mark Kramer. I'm one of the new fellows from Wisconsin. So I have a challenging case to present initially. So it's approximately a 6-year-old gentleman who was referred into our center. He's got a remote history of a type 2 odontoid fracture, and he's ultimately presenting with neck pain after multiple operations. Got some typical comorbidities: diabetes, hypertension, COPD. He's also a notable tobacco user, a current smoker. He had some previous surgery on his low back, and then I listed all of his cervical operations here. So we'll just kind of briefly run through these. So many years ago, he had an anterior cervical discectomy fusion, and then spinous process wiring posteriorly, and this was many years ago. This was for cervical myelopathy. About 5 years ago, before presentation to us, he ultimately presented with some adjacent segment disease proximally. So he had underwent removal of that plate and then a 4-5 ACDF. And then subsequent to this, he developed essentially pseudoarthrosis at 4-5, and the referring group decided to do a posterior laminectomy and fusion from 3 to 6, which, and then a year after that, approximately, he developed distal junctional issues in recurrent myelopathy, and ultimately underwent an ACDF at C7T1 and a revision of his posterior fusion from C2 to T2. It's at this point, not long after this operation, when he had a mechanical fall, which resulted in a type 2 odontoid fracture, and then subsequently underwent a few occipital cervical fusions, and we'll review those just briefly. In terms of his exam, he's a 6 foot approximately gentleman, BMI 25. He actually presents to our clinic in a cervical collar. He's a bit kyphotic in his overall posture, but he's able to ambulate with a cane He reports normal bladder bowel function. He's got some mild right hemiparesis, which he reports has been stable for quite some time. He's also got some sensory deficits, more so in the upper extremities bilaterally. Here's just a brief kind of overview of kind of the evolution of his construct. So you can see that this was after he had already undergone the 3 to 6 posterior cervical fusion on the far left. And then as you march to the right, this is kind of the evolution of his construct. So I guess we can maybe pause here. This is his imaging fairly early after he had his mechanical fall, resulting in this type 2 odontoid fracture, as you can see here. And this was the initial treatment choice that they elected to proceed with. Any thoughts about the choice of this construct?
So Dr. Lockey, were you able to see these images? And if you can keep scrolling through that sagittal, maybe stop it somewhere in the midsection. So this is a pretty shocking case, and there are many things to talk about. We don't want to focus on type 2 odontoid fractures, which are obviously always a problem. Healing impaired patients, nicotine use, social dysfunction are a big problem. And then how to treat odontoid fractures, and this might be a good talking point, above long cervical fusions. So the surgeons in this outside institution in another state decided when there was a type 2 odontoid fracture above a long fusion to go to the occiput. Is that a good idea?
So that was going to be my next question: is what was the decision-making process?
Sorry, we can't hear you right now.
Can you hear me?
So you're not. Dr.
you
Kramer,
hear me
in
now?
Wisconsin, what would you have done? You're from a very reputable place. There are numerous big hitters in spine there. What would you have done? A type 2 odontoid fracture above a lengthy neck fusion? What would your teachers have done?
I think we probably would have elected to just extend up to C1.
How would you facilitate that? How would you do that?
So in this case, he's obviously had issues with bone healing in the past. I think we would have elected to do C1 lateral mass screws, kind of tie into the construct below, and probably would have harvested iliac crest, which would have probably given us the best chance of fusion.
So you would have, in other words, done everything possible to avoid fusing the craniocervical junction, right?
Yeah, I guess that you raised a good point. That is if we're pushed to surgery. Some people probably put a collar and, see if, he can even develop kind of a stable, pseudoarthrosis.
So Dr. Lockey, are you live again?
I'm here, Dr. Chapman. Can you hear me now?
Yes, now we can hear you. A little bit silent on our end here in our facility, but yeah, go ahead. So this patient had a occiput fusion done. This is a clearly healing impaired patient, type 2 odontoid fracture, posterior oblique pattern, if you use the Jonathan Grauer terminology. And the surgeons tried to, I think twice, if I got that right, fuse him to the occiput and increasingly desperately put plates in there. You can see them eroding into the skull base. He has no drainage from there. But would that have been your first choice when you have a type 2 odontoid fracture above a healing impaired long cervical fusion patient?
No, I think, and that was going to be my question, is what exactly was the decision-making process in going to the occiput? I think with modern instrumentation, our fixation at C1 is so robust now. I mean, I really try not to go to the occiput, particularly in a case like this. I think, obviously, physiologically, this patient has poor protoplasm. I think I saw on the previous slide active tobacco use, but I would go to C1. I would probably try to take down the C1-2 facet joints, get good bone grafting in there, and do everything I could to avoid going up any further.
Now I asked Dr. Kramer to scroll through the sagittal images. So we park in one of the occipital cervical junctions. So now there's partial erosion of the skull base. I know during your time with us, you saw a similar case. This patient just appeared in our recent couple of weeks in our clinic. What do we do now? Are we obliged to go to the skull base? I mean, the craniocervical junctions, the occipital cervical joints, OC1, actually look pretty well preserved, right?
I agree. And looking at that CT scan, there's really minimal arthrosis in the occipital-cervical joint. So I would err on the side of just removing the plate and trying to get fixation into C1 and focusing our bone grafting and revision there.
And I didn't see, Dr. Kramer, I didn't see any hardware in C1, right? So they had actually never tried to put hardware in there. C2 screws are a little bit problematic. Did you get us a CT of that? There's some desiccation going on there, an
Yes,
axial cut?
So actually, this is the first
Oh, from the okay,
operation.
go ahead.
I can jump on to so this is after, he ultimately presented about a year later after this initial OC fusion attempt with continued neck pain and weakness. And so that they ultimately elected to reattempt the occipital cervical fusion. In this case, as you noted, all that bone along the posterior fossa had kind of eroded, so that they were forced to kind of move the plate quite a bit more cephalad. And then in this case, they ended up using fibrillar strut grafts. And I've got another axial image which shows that they actually, what they did at C2 is they put translaminar screws. I've got that here.
I would call them improvised translaminar screws. So well prepared. Thank you, Dr. Kramer. Sorry, I preempted that. But so they used structural allograft in there, and there's hodgepodge of screws. So now we have allograft in there. So this is obviously one of the greatest challenges of fusion, I think, in the body is the occipital-cervical junction right next to L5-S1, really difficult. So any thoughts on bone healing now? So this has actually gotten worse rather than better. Was allograft a good choice? Would there have been a better choice? What about autograft in a patient like this who's clearly healing impaired?
Yeah, I think we all struggle with the challenge of how to get the occipital-cervical joint to fuse and get that bridge. It's just such a large jump distance. And in a patient like this, if you really are going to try to go to the occiput, I mean, the gold standard is obviously the iliac crest. You worry about donor site morbidity and the complication profile with that. But multiple revisions, you're looking for doing everything you can to get the biology of this to heal. And I think prior to proceeding with any revision, you need to make sure nutrition is on board and that he has adequate nutrition, and has stopped all nicotine use before you'd ever consider doing anything further.
So you said the nicotine word. So why is nicotine so bad for bone healing? Are you going to go into that?
I'm going to touch on it briefly in the talk, but we can go into it a little bit here. But that data is actually it's very old. It's been well known since Tom Whitesides did his basic science research after he noticed in his clinic that patients who smoked really had a failure to fuse, and he was one of the early advocates for not doing fusion surgery in patients who use nicotine. And the reason for that is nicotine impairs angiogenesis and it degrades tissue. It's one of the key preoperative factors that really prohibit me from proceeding with any sort of instrumented case, because the failure rates are so high and the complication profile is prohibitive.
Great. So any new thoughts? What are we doing now? So this actually got worse rather than better. He has no drainage, right, Mark?
No. So one understanding is well healed. But so I guess my summary of this whole adventure for this patient is that correct choice of construct from the onset. And then I think, going back and from the best I can glean from the operative reports, especially in a patient that has, impaired bone healing, do everything you can, belt and suspenders. There was never mention of any use of iliac crest, for example, to obtain that fusion between C1, C2, nor was there use of BMP, it sounds like, on that initial OC fusion. On the revision fusion, I think that there was BMP used, and they obviously they used these fibrillar strut grafts, but I think I probably would have elected to do iliac crest and BMP for that initial attempt.
It's a very problematic mechanical fixation and very suspect bone grafting. I think your point is well taken. And I'll ask Dr. Lockey for a commentary, and then we'll have to go to the next case. Is iliac crest graft, if taken from a patient himself, so autologous iliac crest graft, still the so-called, quote, gold standard, or is that archaic?
I think it depends on who you ask. I would consider the quality of the bone graft to be the gold standard. I think there's good data to support that, but the morbidity, the donor site morbidity is significant. I think that's why we've trended away from it. I mean, you're looking at a patient who's multiply revised. Looking at that CT scan, the one good piece of news is it looks like the C2 pedicle corridor is still open. They never tried to instrument it. You do have options for getting robust proximal fixation. But to answer your question, I do still consider iliac crest to be the gold standard when we consider use of bone graft.
Okay. All right, excellent. So healing impaired patient, complex fusion, craniocervical junction. We have to solve significant psychosocial problems in this patient first, and he has to undergo nicotine cessation and absence of drainage. We didn't see any immediate need to jump in on surgery. And pending resolution of those factors, we are actually doing what you're saying we should do, which is hardware removal, bone graft cleanup, and we will focus on a quality C1, C2 fixation, possibly with autologous iliac crest graft. By the way, I just want to mention the use of bone morphogenic protein, abbreviated as BMP, is off-label in the posterior cervical spine. I want to make that very clear. And the front of the neck, it's actually considered a black box warning. So we have Dr. D. David Davis III, an immediately past graduated fellow, who wanted to present a patient with a different slant of problems. Dave, are you live?
Yes, I'm here. Can you hear me okay?
Loud and clear, and you're in Illinois now?
I'm in Illinois, yeah. So thanks for having me back. I appreciate it. So I sent my slides. Hopefully they're up. I'm looking at them here on my end.
Yes, we're seeing them.
Awesome. So no disclosures, as obviously. So this patient is a 60s-year-old female with a history of end-stage liver disease, end-stage renal disease, polysubstance abuse, hepatitis C, and progressive upper extremity pain presenting to multiple outside ERs, and previously diagnosed with radiculopathy. She has a forward head posturing and surprisingly no overt motor deficits. She has global weakness associated with pain. In her lower extremities of note, she does have knee flexion contractures, which are obfuscated in this Asian motor table. Probably not the most thorough motor exam, but I did take what they had from the outside facility on the initial report. If we go to the next slide, you can see a progression 10 months and 1 month prior to her initial presentation. You can see her forward head posturing and head progressively resting down on the chest, described recently by Dr. Theologis in San Francisco as the fentanyl fold. Next slide should be a video which will show dislocated facets. You can see the primary pathology at the C7-T1 juncture where you have dislocation of the facets and this progressively worsened forward head posturing. We can advance to the next slide.
Oh yeah, good.
Also included an MRI. You can see this is actually, and keep in mind, these images are with her in a supine position. So she does have a little bit of passive mobility. Clinically, when sitting upright in bed upon an examination, her head is all the way rested down on her chest. She has no ability to hold her head upright. So I'll give a pause. Some considerations for this patient. She surprisingly was not acutely myelopathic. Most of her symptoms seem to be related to her radicular symptoms, and then her mechanical symptoms of having her dislocated facets and her forward head posturing. Obviously, an airway would be extremely difficult. And then the questions of her bone healing and her coagulation cascade, having a healthy coagulation cascade with her liver and renal disease. So I'll pause for Dr. Chapman, see if there's anything you'd like to add.
Patient and Dr. Lockey, this patient, I've rarely gotten more phone calls from literally every clinical entity in the hospital, various internists, infectious disease doctors, the nurses, because this patient's head clinically was actually next to her chest. It's hard to describe, but These supine images don't do the head position justice. She literally had kind of fallen forwards and to the side. So that extreme cock-robin torticollis posture. And Dr. Theologius, as D3 kind of mentioned, this fentanyl fold posture is very difficult. So what do we do now is a dislocated head. Everybody is clamoring for something to be done. And she has every biologic contraindication to surgery: cirrhosis, end-stage renal disease on dialysis, severe prolonged fentanyl use and other drugs, and very deplorable state, non-ambulator with knee flexion contractures.
And I think the important point that D3, it's good to see you again, by the way.
You too. Thanks, Doc.
The important point here is that the patient's not myelopathic, right? So there's, I guess, no reason to do anything in the immediate acute setting. There's a lot of physiologic problems that have to be teased out. Did we have a DEXA scan in the workup? Do we know her bone quality, especially with her medical comorbidities and end-stage renal?
We have HU units, but no DEXA scan. This patient literally, I don't know how to tell you that, had her head next to her chest.
Yeah.
But there's a movie Beetlejuice where they have that character who kind of has their head next to their chest. Corey knows what I'm referring to. But I don't want to mock the patient, but this is a pretty extreme thing. Again, everybody in the hospital this patient called me and went like, you got to do something, you got to do something, do something. Right?
So,
Same call. There's a very strong sense of do something, and we obviously want to do the right thing, and we would like to practice safe medicine, and I did not know or anticipate how dramatic this patient would look in clinical practice, but she looked pretty bad.
So in terms of helping her, I think obviously you're looking at a front-back cervical deformity reconstruction. This is somebody that I'd have nutrition involved and likely do a PEG tube preoperatively. The dysphagia risk for this is exceptionally high. Nutrition postoperatively is going to be important. There's the question of the coagulopathy and how you optimize that, but I'd probably begin with multi-level anterior cervical work just to get the alignment better, and then you're going to need that anterior column support in biology to help with fusion, and then when you go into the back, you're looking at a long construct fusion, likely C2 down into T4, depending on how much correction you get from the front, maybe even some osteotomies.
So you have a practical question. If you go back to that CT or forward actually to the CT, I look at something called the manubriovertebral axis angle, and again, this was the patient supine. How do we get to the anterior column in a patient like this when the manubrium is so high? Do you know what I'm talking about? So it's a very difficult access.
Sure, absolutely. Yeah, I think the MRI showed that the patient does correct a little bit. So I think one of the strategies I've employed is I do put the patient in Gardner-Wells tongs, a little bit of traction, have my neuromonitoring available, and get lateral radiographs to see how much correction we get. I agree the manubrium is high. Question is, how low can you get, and do you engage your ENT partners to help you get down into the C7, T1 region in this particular case? Based on the CT scan, I don't know if the manubrium was prohibitive to get to that level if you were going to do an ACDF there, but at a minimum, you could address the more cranial levels and then address the apex of the deformity from the back if you didn't feel like you could get to it.
So this being a dislocation and a patient without the benefit of a DEXA scan, but with some pretty pitiful HU, Hounsfield units, that is, readings, we decided to go from the back. D3, do you want to tell us or take us forward?
Yeah, I'd love to talk. Yeah, I think those are all really good points, and we considered all of those things. I think at the end of the day, with the facet dislocations and all of the things that we just mentioned, we decided to go posterior first, potentially definitively, with a plan from going some C2 to T7. You may know upgoing hooks on the scout film, and I tried to put side-by-side films to show a pretty dramatic correction. Obviously, the airway was pretty difficult for our anesthesia colleagues, who are excellent here. The bleeding was robust, as you would imagine, in true end-stage liver and renal disease. Very difficult procedure. You may note on there, you'll note C6 pedicle screws, as well as C7 pedicle screws. On the next slide, you can see CT scans that show maybe a little bit more definite picture there. So now you can see the manubrium angle is much more advantageous if a front surgery was considered. We did have pretty extensive conversation about how edematous would her airway be in the immediacy after surgery, as well as the discussion about a PEG tube, I think is a very good one. Actually, I really like being on Zoom because I can see the great comments. There's somebody mentioned the possibility of traction for 48 hours after a PEG tube prior to surgery, which I think is not a bad idea either. But here you can see enough of a correction that I think an anterior surgery would be possible. The question becomes when and if you do an anterior surgery when you have this sort of correction in this patient.
So good friend, Dr. Greenwald, thank you for your comments and thank you for watching. Vitamin D, TSH, and PTH, absolutely important points. Bone density, as mentioned, we measured it in HU units, but we had a relatively acute care situation. So these things will all have to be sorted out, but you can assume that all of these are deplorably low.
Yes, I should have included them, but yes, what we had in the immediacy before her surgery was all not advantageous.
And the traction for Dr. Younghain, yes, if you have a striker frame with a turning bed setup, that's fine. We don't have that here. Sorry, excuse me. So that was not a possibility for us. We actually, one of our fellows, Dr. Brian Anderson, was a saint. He stood there for over half an hour holding traction on the patient and slowly getting her head down into a straighter position whilst holding manual traction with GW tongues until our anesthesiologist had a fiber optic intubation. And you can see we really utilized our screws to get maximum purchase into her. We're very worried about the distal junction. Now comes the question to you, Dr. Lockey. So we don't have an anterior reconstruction yet. And your first thing was we need to do an anterior reconstruction. Look at the bone now. Should we, in this very healing impaired patient, go in on the front and reconstruct her from the front also, now that we have a very much better angle for approach, and we have a mechanically better and more advantageous situation due to the posterior fixation? Or should we be tempted to rely on the indirect healing result afforded by the posterior fixation, which is large bore rods? I think D3 we use 6.0 rods crossing the cervicothoracic junction.
We did.
What are your thoughts, Dr. Lockey?
I think you got great correction there, Dr. Chapman, and I think this is a great example of a very strong indication for subaxial pedicle screws, which speaks to your skill set here, because you get obviously much better fixation, particularly around the apex of your deformity. And I don't think after looking at this that I would be in any rush to go in back through the front, particularly in a patient with these medical comorbidities after the correction you achieved. And you felt like your fixation above and below was robust enough. I think you can stop here and watch this.
Dr. Askuian, what do you think? He's joined us now. Dr. O, rely on indirect healing in the front, or make it a fait accompli and reconstruct the front of the neck?
I think you'll probably have to go from the front. I mean, her bone biology does not look good. And, when you fuse that many levels, usually it's the distal junctions and subaxial spine. So I think it's fine to wait, but I think you're going to have to go from the front.
Hopefully in the future we'll be able to have global polling with our Zoom thing. We've tried that on a couple of visits and sessions, and it's a little bit difficult sometimes, but I'd love to hear what the audience thinks, so it should go from the front or neck. I'm very torn about it. Dr. Lockey, if you've had to follow our senior attending Dr. Oskuian's advice, what would you recommend we do in the front to achieve best possible healing?
I would probably do multi-level standalone ACDF, and I think probably 4, 5, 5, 6, and 6, 7, and if you could get down to 7, 1. I wouldn't use any BMP, probably DBM, for the reasons you mentioned, it being a black box warning. And I think that would give you enough anterior column support and hopefully the biology you need to give you a solid fusion in the subaxial spine.
Yeah, so I'm probably going to use a fibular allograft if we go from the front. We're still looking at her. She's actually done very well. D3, great job. This is one of his last cases that he did. I don't want to specify the date of surgery, but he did a great job in the middle of the night taking care of her. But so far, she's actually done very well, but I'm still not sure whether to go from the front or the not. I'm going to ask our fellows who are in the room here, the new fellows, who have to take on this patient. Would you want to fuse her? Hands up. Yes? Yeah, go anteriorly. Or wait for healing.
I would wait for healing personally, just get it going.
Wait for healing. Wait. Cliff, wait. Wait.
I agree with wait and optimize as best as possible.
Wait, okay, so the fellows are in disagreement with Dr. Oskuyan. We have. All right. We have a new fellow here. Tell us who you are and where you're from.
Hi, my name's Colin Gold. I'm a new fellow and just graduated neurosurgery residency from the University of Iowa.
Great to have you here, another institution, and see your case, Colin.
So we have an 84-year-old man, relatively healthy, 84, with few medical comorbidities, non-smoker, had a lumbar spinal fusion at an outside hospital done 6 to 7 years ago. Was doing okay until 2 to 3 months ago, started having severe low back pain with no sudden onset, no apparent trauma. Feels that his legs are weak and unsteady, making him walk with a cane. Mobility is extremely painful for him. And then we see the x-rays up on the right side here, prior L2 to S1 posterior fusion with interbody grafts at every level. Here's his physical exam from clinic, and this is his first presentation to clinic. You can see he has generally intact except some diminished sensation below the knees bilaterally, which actually occurred right after the first surgery. And then he has diminished strength in dorsiflexion on the right side, as well as EHL on the right side. And then here is a CT.
So there's, again, a lot going on there. So we have a dish spine in the lower thoracic spine, just in the interest of time. We have an adjacent segment disease above a fusion, which is not unpredictable. And then the bottom, we see this parrot beak. It's almost a cannery kind of beak formation with intussusception of the cage into the vertebra and screw loosening. So how would you rate this union, the state of union at the bottom of the spine there, Dr. Lockey?
This is like a basically classic sort of bone healing principles where it almost resembles a hypertrophic non-union. So it looks like that level pseudo, the cage is subsided, large osteophytes that are bridging anteriorly but that are not quite united. So when I look at this is really a classic case of incomplete or inadequate rigidity at the lumbosacral junction.
How do we avoid that in the future? Everything else healed well, so this patient seems to have good healing potential, and he has a spontaneous bone former, as he shows us with his dish spine, or even, this might even be ankylosing spondylitis. It's some mixed form of that. So he's a bone former. Why did that happen? How can we avoid?
I'm going to touch a little bit on the lumbosacral junction in my talk that's coming up, but I think, when I tell residents and fellows, and one thing I've learned as I go out into practice is that L5S1 you really have to take seriously. And, if you're Frank Shen, who's our division chief, you can do L4 to S1 TLIF and the alignment's perfect and the great biology and it heals like gangbusters, but you have to use the tools within your repertoire to deliver a reliable operation. And right now at this stage, I love ALIF for L5S1. You get great disc prep, great biology, you get great alignment. So I think you need to have the alignment on target, you need to have rigid anterior column support, and then you need to have a low threshold to supplement your lumbosacral fixation with pelvic fixation if there's any concern. And you need to abide by the principles of rigid stability and biology to get this level to heal, because the sacrum is a rigid bone. To the motion segment of L5S1, it's a transition zone, and it does not want to heal.
Colin, at your institution, Iowa, you see a lot of difficult cases. Is this something you saw, and what would you do? So you heard ALIF. Is this development a surprise constellation to you?
I think possibly because this guy didn't really have a ton of risk factors for non-fusion. I mean, dealing with it going forward, I would say revising it, definitely focusing on that L5S1 level and extending rostrally would be the plan of attack here. Of note, he did also have a DEXA scan prior to any kind of intervention, which was 1.1, so normal bone. And then he also has an MRI, which just thoracic spine, but you can see the adjacent segment disease and kind of mild to moderate canal stenosis up in
So very typical thing, poor bone stock, probably spontaneously fused spine, older patient, mechanically inferior L5S1 fixation with poor bone substrate and mechanical offloading. And now he has a non-union at 5.1 with probably significant foraminal disease or encroachment due to the subsidence of the cage. And you were involved in the redo? Were you involved in that?
No,
Okay.
this was before my time.
All right, so the week before. So let's see what was done. Dr. Lockey, you said go from the front?
Correct. I mean, for me in this case, I'm doing the front, I'm doing a 5-1 ALIF, I'm turning posterior, and then I'm going to go down into the pelvis to get L5S1 to heal, and then to address the adjacent segment. I think was that was at L1, L2. So yeah, I agree going up to T10.
All right.
So they ended up doing hardware removal and then posterior only instrumentation from T10 down to pelvis, 3-column intradiscal osteotomy at L5S1, L1, L2 TLIF, and the bilateral cages for TLIF at L5S1. And then postoperatively, the patient had an uncomplicated hospital stay, just expected low back soreness, neurologically intact, and ended up discharging to a sniff on post-op day 4. Here is a post-operative CT scan. Oh, also BMP was used at the revision surgery.
So your thoughts on anterior versus posterior? So our partner, Dr. Mia Abdul-Jabbar, did a beautiful job. He did a posterior redo on this entirely. Any thoughts with that, especially in light of atherosclerosis and there being this large parrot beak in the front? Is that reasonable?
I think it looks great, and very very well done. Nice to do cages on both sides to get that rigid stability and extra biology, extra disc prep. Quick question: when we say BMP was it used in the disc space and the posterolateral gutter, both, or just one or the other?
I think both.
Both, yeah.
Dr. Abdul-Jabbar, yeah, and pelvic fixation. So better posterior fixation. The patient, note, by the way, has spontaneously fused SI joints, so putting pelvic fixation there's a really good idea, and actually pretty nice realignment, I think. So, and the patient told
Hey, Jens, can you hear me okay?
Hey, oh, cool that you're here. I didn't see you in the folder. Yeah, so tell us.
Yeah,
What
just wanted to give a couple comments. I think in a large construct like this, going back into that 5-1 disc, that disc space was, sorry. Hold on one sec.
Excellent.
Give a little say hello to everyone, Rain. No, that 5-1 disc was just basically had no disc prep done. When we did it with an open IDO, it was really just almost like a virgin disc outside of where the implant was. And I think that's probably the reason that he had the pseudo there.
Really good point. I see that a lot. I think both of us see that, and Dr. Screen sees a lot. These 5-1 cages are just shoved in there. It's minimally invasive surgery, minimal disc prep also, and not much chance for bone healing. Beautifully done. Patient did well also.
Yeah, I mean, he did really well. Obviously, he was very limited in terms of his.
Oh, mic got muted. Okay, so let's go for our next patient, but beautiful case. And there's, again, this congruence of mechanical instability and lack of bone healing, and maybe not getting the best possible chances for bone healing to occur. So next we have Dr. Minisali. Tell us where you're from, and again, welcome to our new fellows to Seattle.
Yes, good morning. So I'm Nick Minisali. I'm coming from Jefferson Health, New Jersey, and I'm really excited to be here. Thank you very much.
Yeah, so Dr. Haneen, thanks always for joining. Iliac crest may be enough for damage in the vertebral disc. Reconstruction after vertebrectomy, what's the preferred choice in absence of a cage? So before Dr. Minisali runs into his case, Dr. Lockey, any thoughts on what to use for a corpectomy if you want to use autologous graft? Do you use a rib, a fibula? What's a good corpectomy reconstruction alternative to iliac crest?
When I've trained, we've used fibular strut as
We
a
lost Dr. Lockey. We'll come to the question back again, so go ahead.
Sure, yeah, I think that's a kind of an appropriate segue for our next talk. So this patient's 82-year-old male, recent 3-week history of progressive difficulty ambulating and lower extremity numbness, who presented with sudden onset of atraumatic worsening of this numbness from his chest down, as well as worsening difficulty with walking and back pain. Notably, a year ago, he was treated conservatively at an outside institution for what was called a T7 vertebral compression fracture. Otherwise, he's a healthy gentleman with bradycardia and polycythemia vera, not a smoker, no alcohol use. Again, normally walked with a cane prior to 1 week ago. Now he needs to use a walker. Lives with his wife at home, and on exam, generalized decreased sensation from about T12 down with bilateral non-dermatomal decreased sensation. Physical exam, motor exams relatively normal, but could not elicit reflexes in the lower extremities, but negative Babinski, no clonus. So imaging demonstrated this destructive T7 pathologic fracture, which was largely lytic and was causing very significant cord compression. Here we have our axial MRIs.
Nice juxtaposition, by the way. Thanks for doing that, Nick. T1's introduced. So severe cord compression. Do you know what the SIN score was?
Yes, so I have his CT as well, just for a quick look there. But his SIN score was 12, kind of putting him in the indeterminate category.
So it's not a super fast growing lesion. There's some septation, some host response cortication. But again, the patient had a underdiagnosed fracture at T7, treated in an outside hospital. So this in retrospect was a pathologic fracture, not from insufficiency. Any thoughts on this now? So the patient is myelopathic. Thank you, this is very cool. SIN score is at the high indeterminate level. Severe cord compression, clearly myelopathic. What to do and how to reconstruct. Again, we're not talking about oncology here, Dr. Lockey, but we don't have the luxury of a biopsy with a 5-day waiting time. How do we reconstruct this? How do we get this cord decompressed?
Yeah, I agree with that degree of stenosis. I don't think you wait on that. For tumor markers, I think you take this, decompress it, go as wide as you can, robust fixation above and below, and then I think you're looking at doing an anterior column reconstruction, costotransversectomy, and corpectomy for something like this.
And what would you use for bone graft? Can we collect local bone graft? Do you wait for the pathologist to tell us what the fresh frozen shows?
It's always the challenge with these tumor cases. So I don't, and the ones I've done, I don't use any local bone graft, because obviously the concern for tumor within the cells. So I'm using allograft and biologics, DBM. Try not to use any sort of BMP in these cases just because of the tumor history. And I always talk to the patient about beforehand, the risks of healing versus using some of these stimulating factors, particularly in the DBM. But I don't like relying on allograft alone for the reconstruction just because I think the healing risk is so troublesome.
Excellent points. And again, Dr. Haneen previously asked if you have to do a corpectomy and reconstruct it with bone graft, what would you use as a bone graft substitute for a vertebral body? Rib, fibula?
Oh, if we're using a structural allograft?
Yeah.
I use fibula.
Sorry, yeah, go ahead.
I would use fibula.
Fibula, okay. All right, Nick, in the interest of time, why don't you tell us what we did?
Sure, yeah, so went ahead with a decompressive laminectomy from T6 to T8, T7 corpectomy and placement of a peak expandable cage using allograft bone. It was, I believe it was morselized, I think it was just morselized allograft bone, but followed by a posterior fusion from T5 to T9, as well as 2 cross links. And the fresh frozen was confirmatory of, or concerning for a plasmacytoma.
So the use of cages, obviously in this situation, is something we would widely do. We chose to do PEEK for radiation access, which this patient will need. Our intraoperative fresh frozen did show this to be likely a plasmacytoma. PEEK is the worst bone graft material in terms of on-growth, right? What do you think about healing chances of PEEK, and should we use PEEK still now that we know that standard PEEK literally is like a deterrent to bone healing?
I don't use PEEK for that reason. I know that people still have strong preferences and opinions on using PEEK, but I like the idea of using titanium cages because of the on-growth. But you know, when you're doing a case like this, you have concern about the postoperative course and engaging your radiation oncologist. If you use a large titanium corpectomy cage for the reconstruction, you get a lot more scatter with the radiation if that's part of the postoperative treatment course. So, you know, I don't have any strong opinions on use of PEEK. I personally err on the side of using titanium for the on-growth potential. But, you know, I think to each their own preference.
Dr. Skuyan, would you use PEEK here or titanium? Are you on the Lockey camp of stronger, better, or do you help your radiation oncologist with PEEK here?
I mean, honestly, I think either one. You know, I don't have a preference. I know that, you know, like for post-op radiation, it's, you know, people talk about, you know, scatter effect and things like that, but I think using titanium is fine, especially now with all the imaging and everything, I think so.
So in bone healing wise, this is one of those things where the companies really tell us that they have these great bone graft materials, these substitutes, these DBMs. What did you use in Philly at Rothman?
Mostly DBM, yeah.
Yeah, so they tell us to use these frozen preparations and all that. Did you have any cellular matrices or anything like that that you preferred? Don't use product names, please. This is CME.
Right. Not too much. No, most commonly was autograft mixed with DBM. That's mostly what we use.
Gelatinous. Without using product names, Dr. Lockey, are there any product considerations, just in general principles that we should look for? Do we have to be concerned about gelatinous carriers? Do fresh frozen bone cells help or not in terms of getting bone healing?
Yeah, I don't use any donor cells. I just you know, I did my training with Steve Ludwig at the University of Maryland in shock, and we had a number of patients who came from outside institutions with contamination, and the revision there is a very, you know, that's a big problem. So I stay away from anything that has donor cells in it. I think use of allograft in this particular case, and then I do use DBM. I think DBM fibers are helpful, but you do need to just, I think, counsel the patient and document that you counsel those do have growth factors in them, obviously, and this is a tumor case, and you're not using BMP, but I think it's still important to have that conversation.
Right, I think this patient had some problems with his lungs afterwards, but in general, neurologically, he did actually very well. He was able to go home again.
Yeah, he was actually discharged home about 5 days after.
Good. Thank you. So final case before we have our visiting professor lecture. Dr. Hogshead has prepared another case, and I think this is a case of Dr. Oskuyan's. Yeah. So. And I want to thank Dr. Cliff Pierre for helping us organize everything today, and Ben for doing our audio visuals, and Corey for keeping us all organized and on schedule. And
I'm Cameron Hogshead. I'm a new spine fellow coming from Dallas, Fort Worth, Texas area. No disclosures on this talk. This is an 80-year-old female that presented with worsening neck pain and progressive bilateral upper and lower extremity weakness in the ED. This was an atraumatic onset 2 months ago. She said that she kind of had stepwise decline with her left upper extremity, then her right upper extremity weakness, and then weakness of both her legs. She did have bowel and bladder function that was preserved. She was previously an independent ambulator, now requires wheelchair assistance for longer distances. She came into the ED in a wheelchair. She reported significant balance issues and loss of hand dexterity. This is her standing x-ray that she came in with. Her past medical history, she had a non-Hodgkin's lymphoma 15 years ago that was treated in complete remission, hypertension, chronic kidney disease, and chronic thrombocytopenia. Platelets were 122. Relevant surgical history is she had this ACDF 3-4 and 5-6 in 2014 for neck and left arm radiculopathy and weakness. This was all done in a single stage surgery. She said she did get some mild improvement from this, but up until the point about 3 months ago, she was having kind of worsening symptoms. So there, just from that x-ray, looking at it, you can see a concern for 5-6 pseudoarthrosis, and then you've got severe disc collapse between the two fusion constructs at that 4-5 disc space, and then you've got some distal C7 adjacent segment disease as well, with it looks like a little bit of listhesis, anterior listhesis on T1. This was her physical exam findings, so a little bit weaker on her left upper extremity, but globally weak throughout. She did have pathologic reflexes, Babinski, hyperreflexia throughout. She did report some sensation was intact throughout, but she said that she felt like her entire trunk and body just felt different and not normal. She is MGOA 10 and a NEUROP 4, so severely myelopathic, as you pick up from this exam. This is her CT scan here that was obtained.
So that's really nicely presented, Dr. Hogshead. So as we're going through these images, in principle, Dr. Lockey, is an almost leading question. I apologize for that. Is it a good idea to do skip fusions in the neck? What are your thoughts on that? I see this perturbingly often, but maybe I'm just narrow-minded. Is it a good idea to do this or not?
No, I think the die was cast on this once that revision was done and the fusion was floated. I think there's too much stress, and now you have a regional kyphosis focused right on that interspace. So it's I think that this was unfortunate that that second procedure didn't include the level above.
I couldn't agree more. And then again, here we see one level of the ACDF actually healed well, and then the other one didn't. Any reasons why? Is there just bad luck, mechanical stresses? I mean, the surgeon in question was the same surgeon, but one level healed beautifully, the second one did not. Any thoughts?
I don't. Obviously, there's a high fusion rate with single level ACDF compared to multiple. The fact that these were done at separate times, I think probably the motion and the stress related to the successful fusion above may have just placed too much stress on this to heal. It's hard to say. I don't have a clear answer.
Dr. Skuin is the attending on this case. So you actually had an interesting observation there, which I think is important to realize as we're going to hear about non-unions in your presentation.
Yeah, I mean, the surgery was done at the same time, Steve, so it's interesting. I think one was PEEK and one was allograft.
Mm-hmm.
It looks like.
Oh, interesting.
Yeah.
This was there, so this was not a revision. This was just skipped.
It's all done in one operation.
I mean, there's several articles that have looked at non-union rates, and again, I think the top one was an allograft, but one of them is a peak cage. And again, when we get into multi-level ACDFs, the number of non-unions or the rate of non-unions actually rises precipitously with each level. So I don't know what you quote patients. I think you're going to talk about in your presentation later, but if I remember Jeff Wong's paper correctly, when you starting to talk about 3-level ACDFs, whether they're contiguous or not, the number goes into the 50% range, depending on how carefully you look.
I agree. And once we get over 2, I counsel patients that the non-union rate is very high. I think in excess of 50% and even into the 60s, 70s, whenever you're considering 4-level ACDF.
So So now we have multiple level non-unions. We have a severely compromised cord in the caudal level of this older construct. We have subluxation, which is a very typical pattern of C71. The patient probably has some inflammatory disease, right, Dr. Cameron?
No autoimmune. She has a chronic thrombocytopenia that's presumed to be autoimmune, but no rheumatoid arthritis or lupus or anything like that, but maybe small inflammatory.
I was wrong to infer that then. How do we resolve this now? Do we have to take everything out in the front? What would you suggest, Dr. Lockey?
Well, looking at that MRI, the global alignment of the cervical spine doesn't look terrible. I almost in this case would err on the side of doing everything from the back and doing a long construct fusion from C2 to T2 and then decompress those levels of stenosis.
So what was done?
That's exactly what we did. So we opted for a C2, T2 posterior fusion with decompression at the stenosed level, so 3 all the way down through T1, and used local autograft collected from the bony decompression into the lateral gutters for fusion, with C2 pedicle screws at the top of the construct for biomechanical stability, all the way down to T2. And you can see here in the pre-op images on the left, you can see the loss of lordosis, a little bit of kyphosis, and then on the right, we were able to get good alignment as well as achieve our goals of decompression for her and stability.
Dr. Skuin, did you do anything to get more lordosis out of the patient? Did you hyperlordose the rods? Did you drill down the facet joints more? Anything to get her lordotic?
We tried, yeah. I mean, you can see there, she fused at C3-4 and some of the other joints were auto-fused, but we tried to get as much lordosis as possible.
If you, by the way, look at the C1 posterior arch and the C2 posterior arch, if you stop that, Cameron, when you go to the midline, I always love this. One of our former fellows coined that term, so I've named it after him. It's Ishak's side, Bazem sign, yeah, right here. You see how the C1 posterior arch hypertrophies and scallops over C2, and that's basically the, yeah, exactly. That's the attempt at the patient to kind of compensate for subaxial kyphosis by tilting the C1, C2 joint back. My one worry is, and I would have not done anything different, Rod, I think it's beautifully done.
Yeah.
But this patient has C1, C2 arthropathy. So, Dr. Lockey, would you have included C1, C2 preemptively or just try to ride it out?
I would not. I would have gone to C2. You know, I think taking away rotation, going up to C1, it's a great stopping point, anchor if you need it. But if you can get good fixation at C2 and stop there, that's where I would hold off.
So just physiologically speaking, why is it so helpful to go posteriorly? Is it mechanics? Is it a better bone healing surface? When the stress transfer happens in the anterior column, why is the salvation for ACDF non-unions posteriorly?
It's a combination. Our fixation now in posterior cervical surgery is much better than it used to be. And then, you know, we just have a lot of fusion surface area, and you have access to the posterolateral gutter. You can burr into the facet joints, and there's lots of room for bone grafting. So I think between, you know, and your opportunities for deformity correction, if you have to do any osteotomies, going from the back is just so powerful for all those reasons.
So with this, we'll conclude our fellows presentations. Thank you, Cameron. Yeah. Thank you to our 4 new fellows, and welcome to Seattle. And thank you, D3, for your presentation, and good luck in Illinois. It's a great pleasure to introduce Dr. Stephen Lockey. He's an assistant professor of orthopedic surgery at the University of Virginia. So thank you for joining us today on this August 7th edition of our STED Talk. And just as a matter of introduction, Dr. Lockey got his medical degree in Masters of Business Administration at Georgetown, and he did his residency training in orthopedic surgery there, and then did a fellowship at the prestigious University of Maryland at the Shock Trauma Center with Dr. Ludwig and their great neurosurgical and orthopedic team concept there in Baltimore, Maryland. And we got to know Dr. Lockey during his North American Spine Society Traveling Fellowship Award. This is a very prestigious prize in recognition of Dr. Lockey's extraordinary and very robust research accomplishments. He's had numerous articles and textbook chapters already, and he has a very keen scientific interest in the field of spine surgery. Maybe most noteworthy of his many accomplishments, he's a absolutely wonderful family father, and has 3 great kids. He's a great guy. We're very privileged to have him here. And during his time here, he gave us a outstanding talk on bone healing, which I thought for the beginning of our year, and as our fellows are going to be exposed to all the advertisements of magic bone healing, would be very helpful to have as a foundation. So thank you so much for taking the time in your busy schedule from Charlottesville, and tell us about bone healing.
Thank you so much, Dr. Chapman, for the very kind introduction. Hopefully everybody can hear me.
We can.
Okay, great. I'm Steve Lockey. As Dr. Chapman mentioned, I've had the honor and privilege to be at the University of Virginia now. I'm coming up on a year in practice. I just want to say, just take a moment and say thank you to the North American Spine Society for sponsoring the Traveling Fellowship. My 2 weeks at SSF and the Swedish Medical Center were really transformative, and spending time with scholars like Dr. Abdul-Jabbar, Dr. Scory, and Dr. Chapman, I can't tell you how much I learned during those 2 weeks. So I want to thank all of you for being such wonderful hosts and for being tremendous leaders in our field. So part of my responsibilities at UVA is that I train residents and fellows. And so I think if that was important to me to put together a talk that really highlighted the indications, and we're going to focus mostly on the lumbar spine, indications for fusion, and then describe some of the basic science and foundational principles on the biology of fusion. But it's also important because we're seeing more and more patients come in with desire for motion sparing technology. And like everywhere else, we're facing insurance companies that don't want to approve care. And so if you have an understanding of when fusion is really necessary and how to do a good fusion, it's going to, I think, be very fruitful for your career. And use it sparingly, but use it when necessary. So I want to start with a case. I know we went through a lot, so I won't belabor this, but this is a 75-year-old woman. She presented in 2019. She had low back and leg pain, and her MRI demonstrated multi-level stenosis. She ultimately underwent an L2, L5 decompression stabilization at an outside institution, which she says completely relieved her symptoms. But she had a fall, unfortunately, and she's now saying that she has pain all the time when she stands and walks and only has relief when sitting or lying down. Unfortunately, she's a diabetic. She does have osteoporosis, and she's currently an active smoker. Her exam was really non-contributory, and these are her radiographs. So you can see there's clearly subsidence of the L4-5 interbody device and absence of fusion mass in the posterolateral gutters. And we got a CT scan, which we demonstrated absence of fusion mass and actually subsidence of the cage at all levels, and loosened screws with haloing. So when we think about the history of spine fusion, I really dove back into the literature and tried to investigate what's our history? Where did all this come from? What are the foundational principles that inform us today that maybe we've forgotten? Well, some of the initial indications were to treat tuberculosis. This is actually before the advent of medications, obviously. So this is Fred Alby's paper from 1930, where he said an advanced destructive tuberculous process in a joint can never be said to be cured except when ankylosis has occurred. And he took a bundle of reeds, harvested intermedial tibial bone graft, split the spinous processes, and laid in the graft above and below the levels of infection. And because the biology and he used autograft, he had very good results with this. We have obviously used for decades fusion to treat scoliosis. So this is Russell Hibbs' paper in 1924, where he's actually quoted as saying, "It's been interesting to observe how little discomfort was felt by children under the constant force of 20 to 40 pounds. Now, this is obviously before we had internal fixation technology. I just cannot imagine doing something like this today. But for most of us, when we consider the indications for fusion and degenerative pathology, it really comes down to this principle of instability. Is there instability present already in the form of a spondylolisthesis? Or is there instability because we caused it? Postoperative instability, did we resect too much? And this is one of the foundational articles that looked at posterior element resection and motion at the segment after the resection had occurred. And this is where this concept, if you take half of both or one of all the facet joints, you should consider fusion because of the amount of motion it creates. But really, the decision to perform fusion is more nuanced than this. This is an article that looked at the biomechanics of a motion segment after you resect the posterior elements, and the load transmission moves anteriorly, which affects the disc and overloads the facet joints, which can cause femoral stenosis from facet hypertrophy. So it's really a little bit more nuanced than how much decompression did we perform when you think about the longevity and the durability of an operation. But it's not just the posterior elements. We know that when you perform a 360-degree decompression, in other words, remove the posterior elements and then do some disc work, that actually adds a lot more motion to that segment. So the decision to perform fusion, as you can see, is much more nuanced than we initially thought. What's the biology of fusion? Any good orthopedic intern can tell you that to have a healed bone, you need to have blood supply, cells, scaffolding, and stability. But think about the spine. We're taking two vertebrae that were never meant to be united and trying to get them to heal together. This is why we're dependent on bone grafting, one of the most important parts of the case, and it's actually at the end of the case when we're tired and trying to get through things. So it's an important time to pause and make sure we do it well and that we understand bone grafting technique, because it's not just the type of bone graft, it's the morphology. This is a basic science paper that looked at oxygen tension moving from the surface of bone graft towards the center, and the amount of oxygen penetration actually drops exponentially. Once you get beyond 2 millimeters, there's essentially not enough oxygen to support viable cells. So it's not just the type of graft, it's not just the components of the graft, it's the morphology when we do the bone grafting technique that matter. I wanted to understand what's the role of prostaglandins and NSAIDs, because we're concerned about opioid administration, obviously. What's the role of anti-inflammatories and postoperative pain control? Because prostaglandin 2 upregulates the RUNX2 pathway, obviously facilitating osteoblast differentiation. And I looked back through the literature. This is one of the original articles published in 1998, founding a dose-dependent relationship between ketorolac and non-union after fusion surgery. This is an animal model which indomethacin was administered to animals after an attempted fusion, and they found there was robust infiltration of fibrous tissue in animals that received the NSAID compared to those that didn't. This is another animal model in rabbits in which they found there was a time-dependent relationship. In other words, the animals that received indomethacin early on after the attempted fusion were more likely to go on to non-union than those who received it later, and controls. But this is not really borne out clinically. When you look at a meta-analysis of non-union and NSAID administration, this is a meta-analysis that was published, and the authors reported that as long as you use less than 120 milligrams per day of ketorolac, the non-union risk is really not significant between those who receive NSAIDs and those who do not. And this is a more updated meta-analysis in which the lower quality studies were excluded and there really was no association. So I think for me in my practice, I do use NSAIDs for those we're concerned about postoperative pain control. Mobility after surgery is important, both from the standpoint of preventing complications and expediting recovery, but I use it sparingly and I use it with caution. But it's not just the actual growth materials within the bone graft that are important. The decortication process is critical. When you decorticate the transverse process, this is an animal model that shows this robust angiogenesis that occurs, and that is not so. It's not the case, obviously, if you don't perform the decortication. So this step, the last step of the operation for many of us, is actually critical to have a successful fusion. It's not just the fixation. And, when we think about decortication, I go through this with the resident fellows. What are we decorticating and why, right? So the transverse processes are cancellous bone. They bleed. They get a robust angiogenesis response, but the jump distance from one transverse process to the next is significant. The facet joints are also cancellous bone, and obviously the jump distance from the inferior articular process to the superior articular process is far narrower. And so that's a critical area to do our decortication and actually preserve some of our bony architecture if we can when we're doing our decompression or say an inner body. But what about the pars? This is a histology slide that shows the pars is actually cortical bone. And if you burr the pars intraoperatively, you'll see it doesn't bleed very much. So the question is, should we be burring the pars? I don't know the answer to that. I do. I was trained to do it. But the pars doesn't bleed. Are we just introducing dead cortical strips into the gutter? And are we compromising the stability of that motion segment? I don't know the answer. I do burr it. But it's different bone. It's important to understand these basic concepts when we're doing the operation and ask these questions. When you think about intertransverse process fusion, there's really three zones. You have the zone over each transverse process. Again, cancellous bone, robust angiogenesis response, and that heals by intramembranous ossification. The junction in between heals by endochondral ossification actually takes several weeks longer. And this is where the biology of the patient and the stability of your construct really are important. So you have to have good stability. That's where internal fixation pedicle screws are really important. Intercolumn support if you're doing a 360-degree fusion. But the patient's biology, are they not smoking? Are they nutritionally optimized? Do they have a good blood supply? And did you graft appropriately? That's what gets you over this hump at the 5 to 7 week mark. bone grafting has changed, right? We touched on this a little bit in the discussion before my talk, where we used to take iliac crest, you get a lot of volume, but there's donor site morbidity associated with it. You can see these nerves that are in the various corridors that you have to avoid. Patients can develop painful neuromas if these are damaged. And some studies have reported up to 50% of patients experience a complication associated with the donor site, and that doesn't include the surgery itself. So we've really moved away from iliac crest, particularly in the primary setting, and more towards utilizing supplements and local autograft bone. So this is a study that looked at utilization of local autograft, which is important. We can't just burr this material away. You need to harvest it and try to preserve as much as possible. But if you look at multi-segmented fusion, several levels, local autograft is not as good as iliac crest. And there are reasons for that. The quality of the bone graft, the volume of growth materials is not the same as iliac crest. So what other tools are available to us? And this is actually going back in a revision procedure and taking a biopsy of the fusion mass. And you'll see in the center of this bone, there's a necrotic sheet, which is completely acellular. So again, this points to this concept that as you penetrate towards the center of the bone graft, the oxygen tension drops, you don't get good penetration, the cells don't have a viable environment, and they die, and so you end up with this dead sheet. So the morphology and the type all matter when we consider doing these fusion operations. BMP has obviously become an important tool, but there are concerns with this, right? We touched on this. Cost, off-label use, there's obviously a complication profile associated with it. DBM has been a workhorse in my practice. I don't endorse any of these materials. Actually, I don't use any of these products in particular, but I put this up there because it highlighted an important point and something that I learned when I was going back and developing some of this presentation, which is that formation and development of DBM and its preparation is not regulated. So it's up to each industry support to develop their own preparation. And when you're approached about a new product, as you come out into practice, you need to ask, how is it prepared? Are the growth factors preserved? What's the basic science and the clinical data to support it before you use it? Because you can see there's obviously a very different grown both response between these three products. And then you have to take this with a grain of salt because this paper is from the AIS literature. You know, obviously children have a different healing response than adults, but allograft has been compared in this particular study population to autograft, and there really was no difference. I do use allograft to supplement my bone grafting if I don't feel like I have enough volume. So what are the risk factors for pseudoarthrosis? And Dr. Chapman asked about this earlier. I actually had the privilege of speaking with Dr. Whitesides one time. He's an amazing man, did a lot of great work on compartment syndrome, but this was one of his major contributions in our field, which is what are risk factors for pseudoarthrosis? And he noticed in his clinic and then ultimately did a clinical study to show that pseudoarthrosis was much higher in smokers. And then he had the basic science data to support it. And he was one of the early advocates for not performing fusion operations in those who use nicotine because it inhibits angiogenesis and it has degradative properties to the tissue. We also know that alignment is important. Now, this isn't an alignment talk, but for the residents and fellows that I train, I talk about it's a basic orthopedic principle. You learn this when you enter residency. Bones like compression. If you stabilize the fracture such that the fracture margins are seeing compression, it will go on to heal. If it's seeing shear, it will end up in a pseudoarthrosis or a non-union, and you will experience hardware failure. Well, alignment's not just important from the standpoint of the cone of economy, but it's also important from the standpoint of your construct and each segment seeing compression. So when you get the alignment right at an individual level, you're ensuring that that level sees compression and increases the probability of healing. You're also protecting the adjacent segments from going on to developing stenosis and breakdown because they're not seeing shear. So getting the alignment right at each individual level is really important. And this is where some of the automated alignment, the AI, the integrated learning, all those things can be helpful for us in getting each level of fusion to the optimal alignment to optimize healing, okay? It's also, become, as the technology is developed, we're having different technology, expandables, different access points to perform interbody fusion and 360-degree fusion, right? Better stability, anterior column support, better biology, increasing the probability of fusion. But I sometimes think about this with a little bit of caution because I mentioned endochondral ossification, right? That secondary bone healing process, which requires a little bit of motion, right? So there's certain cases where we're having too much stability at a particular state, at a particular segment. And actually, I wouldn't, this is a biomechanics study that looked at just that, where if you have lockdown facet joints and you have a intercolumn fixation, it's the most rigid construct, versus if you just link in the transverse processes, the motion of that segment is essentially that of the spine that's unfused. So is there a balance in between? Should we be considering these? Because if you look at this classification, which I would not recommend anybody memorize, but atrophic non-unions, where the bone essentially disappears after grafting, was found in instrumented cases most commonly. And that sort of points to this idea, well, is there ever this concept of too much stability at a particular level? So how do patients with osteoarthrosis ultimately present? And I think this is really important in the cases that were shown today, excellent, because it highlights the indications, and that if you perform a revision operation in these cases where a patient is well indicated, they end up doing very well. It is a clinical diagnosis that is supported by radiographic findings. So patients may present with new back pain, new leg pain. The important point for me when I'm working these patients up is that they had a successful outcome initially following the index operation. They had alleviation of their symptoms, and then maybe they sustained some low energy fall or some low energy trauma. Then they get recurrent symptoms. They have back pain. Often they have pain with percussion. And so in these particular cases, I have a low threshold for further workup. I wanted to understand, why is it that pseudoarthroses hurt, right? Because we are at a tertiary referral center, we get all kinds of x-rays sent to us, and we see these patients, and you suspect a pseudoarthrosis that looks like the screws may be a little bit haloed, but the alignment's okay. There doesn't appear to be motion. Why is it painful? Well, it's the micromotion. If you actually look at the histology adjacent to the area of pseudoarthrosis, there are these microtrabecular fractures that develop, and then there's surrounding fat necrosis. So every time this occurs, there's this acute inflammatory reaction that results in pain. So patients who have this, and you can tease out the indication of this being symptomatic, will do well with a revision operation. So how do we make the diagnosis? Well, any workup obviously begins with plain radiographs. You can look for screw breakage, haling. Most patients can be diagnosed based on flexion extension views and plain radiography. But if you have a low index of suspicion, or if you need confirmatory studies, and most of us before we're going to do a revision are going to get a CT scan, fine cut. The gold standard traditionally, if you look back in the literature, was actually surgical exploration. That's not really feasible now. So we have fine cut CT to look for absence of fusion at the facet joints. But I would just tell you, the important point here is just because you have what's evident of a pseudoarthrosis on a CT scan does not necessarily mean it's symptomatic. Everything, indications dictate outcomes. So I really, I need a patient to present with sort of the typical findings of a normal postoperative course, good recovery, resolution of symptoms, and then a subsequent sort of a subacute trauma that results in recurrent symptoms, and then advanced imaging consistent with the pseudoarthrosis before I'm going to really make a determination to take that patient back for a revision operation. So when we consider management, this is a paper that discusses failed back surgery syndrome and how to go into a workup and management. Obviously, if you have an open anterior column, using an interbody can be helpful to restore some biology and anterior column support to get the rigidity you need to achieve a fusion. Traditionally, I had always upsized screws, but I've actually learned in practice from my senior mentors, Dr. Shen, Dr. Scheimer, who are just wonderful partners, the technique of performing a pedicoplasty. We're debriding the tissue within the screw channel and then placing bone graft and tapping that bone graft into the pedicle, and you get just tremendous purchase. And sometimes you can even downsize the screw, and that really is helpful for getting good purchase and not needing to upsize screws, which has obvious sort of implications. The other thing I want to just touch on briefly is the lumbosacral junction, because I think, when I talk to our fellow and our residents, the lumbosacral junction is just critically important. It's the base. And if you're going to the sacrum, you have to get it right. Sometimes we get revisions sent to us, and if L5S1 is not done well, it just makes things way more complicated. You almost prefer that they didn't do it initially. So if you're going to do L5S1, if it's indicated, it has to be done right. Whatever tools are in your repertoire to get it done right, utilize them. So for me at this stage, I love anterior column support at L5S1. I touched on this. If the patient is not contraindicated for an ALIF, I'll do an ALIF because I love the disc prep. I love the alignment that I get with it. I love the anterior column support and the biology needed for fusion. The other thing is you have to understand the osteology of the sacrum. So the sacrum is actually void of bone in the ala. the best bone quality is towards the promontory. So getting medial screws here at S1 are really important. I often will do sacral screws on lateral. I'll medialize and I'll aim right for the promontory to try to get robust fixation at the sacrum. There's this concept of the lumbosacral pivot point, right? The sacrum is a long bone at the motion segment of L5-S1. There's a lot of stress here. And so getting this to heal is very challenging. When you think about getting pelvic fixation to supplement the rigidity at this particular location, you have to get anterior to this point, because you think about it, if you're too short or too horizontal on your pelvic fixation, your screws are simply acting as an axle around that pivot point. They're not providing you with the stability you need to get this level to heal. So this is a key concept whenever we're considering lumbopelvic fixation and getting a healing response at L5-S1. So what are the outcomes? And again, I want to preface this, I've harped on this a little bit. Outcomes are dictated by indications. And so the literature here is discouraging when you consider revision surgery for pseudoarthrosis, but I think our literature is biased by the fact that we don't necessarily have the best techniques to tease out who's well indicated for a revision operation. Those cases that you showed in conference are great examples of patients who are going to do well with revision fixation and bone grafting. But this is one particular paper where they looked at patients who had an unsuccessful fusion. Revision resulted in 100% healing rate, but only about 50% of patients actually had clinical improvement. This is another paper that looked at using interbody technology to supplement fixation. ALIF had very good outcomes, but again, only 50% experienced improvement, and then the others less so. So overall, discouraging results. But I think in a well-indicated patient, a revision operation to address osteoarthrosis actually is you have very happy patient population, but it all comes down to that initial preoperative visit. What's the history of present illness, how they did after the index surgery, and what your workup has shown you. So in conclusion, right, understanding the indications for fusion, documenting them well, having that discussion with the patient is critically important. You have to pay attention to alignment. You have to know your bone grafting availability and how to do a good bone grafting technique. Diagnosis of pseudoarthrosis is clinical. You have to have a well-indicated patient before you should take them back for surgery. But if you do have a well-indicated patient and you achieve good alignment, good fixation, good biology, they're going to do well. And so I just want to go back to our case. So, same CT demonstrating loose screws and subsided cages. We end up taking the patient back for a front back. We did 4-5-5-1 ALIF and then revision fixation and going to the pelvis. And ultimately the patient did quite well with this. So again, I just want to thank everyone, Jens, Amir, and Rod so much for having me out there to learn from you and for hosting me today to give this talk. It's just been a real honor, and I feel so lucky to call you all friends and mentors. So thank you so much.
Really outstanding, and again, I want to congratulate you on putting so much information into such a compressed time in a very meaningful fashion and above board in terms of any industry influences. So a couple of questions, two in terms of augmenting bone healing. One is from our good friend, Dr. Alan Greenwald. Pharmacotherapy, is that something meaningful? Teriparatide, romosozumab, any pharmacologic aids in these healing impaired patients? We certainly had a couple of seriously healing impaired patients today in our case presentations.
Yes, and I am fully aware that not everyone has access to this, but one of the things we're very fortunate of in the Department of Orthopedics here at UVA is we have a whole bone health specialist who works directly with us and through the Department of Endocrinology. So I look at Hounsfield units, but I have a very low threshold to get a DEXA scan before I'm going to do any sort of internal fixation, because I have an access point to get a patient plugged in and treated and then get them back to me for their spine care. That problem, this idea of owning the bone, this big push, I think we're very fortunate to have been able to offer that. And I know that that's a challenge because getting in to see endocrinology can be a long wait time for patients with difficult problems. But I do send patients to get treated before we'll do internal fixation if they are osteoporotic.
Great points. And then electrophysiology. So Dr. Carl Brighton introduces to the piezoelectric effects of stimulating osteoblasts with some electricity. is this just a has-been? When I was a young surgeon, we actually put little electrical leads into the posterolateral masses, and it seemed to actually lead to some bone concrementation. So is that just gone? Do these electromagnetic stimulators, which are nowadays usually external, an anachronism, or is they still relevant? Is this a relevant thing to do?
I don't have a strong opinion on using bone stimulators. I have used them. I don't know how confident I am that they help. But particularly in these patients where you're concerned about the healing response, I think doing everything you can to get the fusion to take is helpful for peace of mind for you and for the patient.
So I thought this was a great talk. Rod, any comments?
Yeah, no, I mean, Steve, great job. I think all the points you brought up in your talk are really important, and they're, the bone biology thing's a big deal. Because, we're all, and I learned actually from you guys, all the orthopedic surgeons, I think you guys really emphasize in my training, like the neurosurgeons were more, we're taught a lot more different skills, and I've learned a lot from Jens, especially in the sacral, lumbosacral junction and the pelvis. I mean, these are really difficult areas to get diffused. So excellent talk. Great to see you.
Great to see you.
Now, let me ask you one more question since we have your wisdom right here. So bone graft volume for healing, especially in the lumbar spine, is there some magic formula? Because you said pressure is important for bone healing. And being an older guy, we used to put these plates on the back of the spine and the lumbar spine, and the bone under there actually got compressed and actually healed quite well. So we actually tried to really pack a lot of bone there, literally actually impacted it with an impactor to try to get this to compress. So bone volume and compression of a loose morselized bone graft, do these things matter?
I don't know the answer to that, but what I will tell you is that I try to fill the whole posterolateral gutter, all right? So from the lateral margin of the TP all the way to the facet joints with bone graft, and I try to keep it, it's hard to judge, but I try to keep it no thicker than 0.5 centimeter. And the reason for that is that basic science data that shows that with the oxygen penetration below 2 millimeters, dies off substantially. So I think if you have 2 millimeters above and below, you're getting enough oxygen penetration to keep the cells viable. So I try to do a wide surface area, but overall very thin.
And my final question, then we're truly running out of time, but thanks for, again, all your wisdom and this really cool talk, which is a fantastic foundation for our new year of fellows. And that is when we collect local bone graft, or let's say iliac crest graft, what do we do on the back table? Is there something that we should do besides putting it just into an emesis basin and letting it dry out in the middle of the air? Should we do something to keep it alive until we get it back into the patient?
Yeah, Dr. Chapman, that's a really good point because, as surgeons, right, we're so focused on the actual operation. And then as I mentioned, right, you're laying down bone graft and they're doing the decortication. It's actually a critical component of the case. And if your bone graft is not prepared well, the whole thing is for nothing. So I'm very particular about how the bone is stored on the back table. I keep it moist. And I actually do use a bone mill to mix everything together. And I kind of make a judgment on how much supplement material I'm going to need based on how much local I harvest. But I'm very aggressive with the Lexel Run Jord to try to get as much local graft as I can, just because I think it's the best quality.
Great. Well, we've pushed your knowledge hard, and again, you're a superb surgeon and really good educator also and researcher. So we're looking forward to future interactions with you. And Anna Gorbacheva, our great medical student from the University of Vermont, is here, and we're really excited about our next stage of projects. Thank you very, very much.
Steve, one last thing. It's Jens's birthday. I know he doesn't want to celebrate it, but he was trying to get out of us acknowledging his birthday. He went to Toronto, but he's not going to be able to get out of that. So happy birthday, Jens. And he's got a cool little birthday card from...
Happy birthday. Yeah. Happy 45th, Dr. Chapman.
Thank you, guys. Thank you, Steve. Be well.
Great to see you all. Thank you for having me.
Here.
Okay.
Bye-bye.
Take care.